First, let me begin by thanking the President, Nigerian Cardiac Society, Professor Odili, and the LOC Chairman, Professor Udekwu, for the kind invitation to deliver this year's Professor Fabian Udekwu's memorial lecture at the 53rd Nigerian Cardiac Society Annual General and Scientific Meeting being held in Port Harcourt, Rivers State. I'm indeed honored by the invitation and for the privilege of the podium. The NCS has had a long history of leadership and guidance in cardiovascular care delivery in Nigeria. And this year's theme, Socio-Economic Burden of Rising Cardiovascular Diseases Profile in Sub-Saharan Africa, along with the three sub-themes, which includes the Regional Cardiovascular Center of Excellence, a call for urgent action, speaks volumes about the current health challenges and is a clarion call to advance cardiovascular care in Nigeria to the next level in this 21st century from the foundation laid in the late 20th century by our predecessors. Professor Fabian Udekwu was one of Nigeria's medical giants, a pioneer and a trailblazer who navigated the uncharted territory of cardiovascular surgery in Nigeria, and through his strength of character and indefatigable spirit, attained many firsts during his illustrious professional career. The history of cardiovascular surgery in Nigeria, and indeed West Africa, will be incomplete without this legend. And so it is quite appropriate and worthy that the NCS established the Fabian Udekwu Memorial Lecture in his honor in recognition of his many contributions in advancing cardiovascular care in Nigeria. And so we can still be talking about him almost 20 years after his death in 2006. While perhaps a few of the older colleagues at this meeting might have encountered Professor Udekwu during his lifetime, either as medical students or residents, many of the younger doctors probably do not know much about him. And so I think it's proper to give some historical perspective to put his accomplishment in the right setting. Prof. Udekwu was born in 1928 and attended St. Charles Teachers Training College, Onitsha. And after graduation in 1947, he was retained as a faculty member. He subsequently, after saving enough money, departed for the United States in 1950 in search of the proverbial golden fleece. He had his pre-medical studies in Los Angeles, California, after which he attended medical school at Loyola University in Chicago, Illinois, graduating with an MD degree in 1957. He then undertook postgraduate training in general surgery, followed by cardiothoracic surgery at the Cook County Hospital in Chicago, completing his training in 1964. He was subsequently certified by the American Board of Thoracic Surgery to become the first fully certified Nigerian cardiothoracic surgeon, a landmark event at that time. I need to give a little historical perspective and background during that period in American medical history to fully appreciate his feat. Prior to the Civil Rights Revolution of the 1960s, there was little information or acknowledgement of the contributions of Black Americans to medicine by the American medical establishment, resulting in many blind spots in the American historical panorama, thus giving the appearance that Black physicians did not exist, especially in the field of surgery. From the end of the American Civil War with resultant emancipation from slavery in 1865 to the mid-20th century, Black surgeons were trained primarily through the agency of the segregated Black hospitals. But despite these obstacles, Dr. Daniel Hill Williams, a Black surgeon, made history when towards the end of the 19th century on July 9, 1891, dared the fury of the gods when he successfully operated on a 24-year-old black male with a stab wound to the heart at the Providence Hospital in the south side of Chicago, thus becoming the first in the world to operate on the human heart, a feat which subsequently established his stature as a clinician and a surgeon in the upper echelon of surgeons in America. The decision by Dr. Dan Williams to operate on the human heart was the modern equivalent of Prometheus stealing fire from the gods. The human heart had long been considered a mystical organ since antiquity, and it was thought that any mortal who dared to operate on it was doomed to celestial punishment and social disgrace. This was evident from the statement by Theodor Billroth, the founding father of abdominal surgery and chief of surgery at the University of Vienna, and considered the most influential surgeon of the 19th century, who stated in 1881, quote, "Any surgeon who dared to operate on the human heart will lose the respect of his fellow surgeons," end quote. Up until the mid-20th century, cardiac surgical training for black surgeons in the United States was not available, and the few who did had to travel to Europe to acquire training. This was the harsh reality for the black surgeon at the time of Prof. Udekwu's arrival to the United States. He without a doubt must have faced many of these prejudices and discrimination, but with determination and perseverance, persevered with his training. He returned to Nigeria and joined the faculty at the University College Hospital, Ibadan, where he remained until the outbreak of the Civil War in 1967, when he moved to UNTH Enugu to establish and build a cardiothoracic surgery team. Prof. Udekwu was a visionary, and so, despite the challenges and the aftermaths of the Nigerian Civil War, never relented on his dream to start open heart surgery in Nigeria. And finally, in January 1974, Prof. Udekwu, with the assistance of Professor Sir Magdi Yakub from England, performed the first open heart surgery in Nigeria at UNTH, thereby ushering in the dawn of a new era in medicine, with Nigeria joining the League of Few African Nations to have reached that pinnacle and exalted status in medicine. Professor Udekwu's professional life epitomizes that spirit of tenacity and determination to succeed against overwhelming odds. As once espoused by President Ronald Reagan, and I quote, "There is no height to which the human spirit cannot rise, the only limitations being the ones we set for ourselves." According to Greek mythology, a good surgeon must have 6 of the following qualities: 1, the heart of a lion; 2, the patience of a hyena; 3, the bladder of a camel; 4, the eye of an eagle; 5, the gentleness of a lamb; and 6, but not the least, the touch of a woman. Prof. Udekwu was without a doubt endowed with all these 6 qualities, which is why he was a giant and a legend in the field. Subsequent generation of cardiothoracic surgeons owe him and other pioneer trailblazers in the field a debt of gratitude for their leadership, inspiration, and guidance, and upon their shoulders the present generation of CT surgeons stand to carry on the torch to the next generation of surgeons. Visionary leaders with a sense of legacy and continuity know they must clone themselves, so to speak, by training and inspiring proteges to carry on the vision after their departure from the stage. Prof. Udekwu's 2 proteges, Professor Martin Agaji and Dr. John Okereke, ably filled that shoe and continued his enduring legacy at UNTH, which was subsequently designated as a cardiovascular surgery center of excellence by the federal government. A further testament to Prof. Udekwu's vision and unwavering commitment to the relentless pursuit of excellence. There's an adage in Igbo folklore, translated in English, which states, "The flame or fire that is handed over to a child by the elders should not be allowed to be extinguished in his hands." End quote. The present generation therefore owe these pioneers in the field the obligation and duty to not only carry the mantle to higher and loftier heights, but also to pass on the burning flame to the next generation, so that the efforts of our heroes past who ignited this fire will not be in vain. This therefore brings me to the third sub-theme of this conference: Regional Cardiovascular Center of Excellence, a call for urgent action. Advances in medical technology in recent decades has resulted in a paradigm shift to less invasive strategies for treating cardiovascular disease. With the explosion in structural heart disease therapy, such as transcatheter treatment of valvular heart disease involving aortic, mitral, tricuspid, and pulmonary valves, thus a line extension of life-saving treatments to patients who ordinarily will have been denied open heart surgery due to high operative risk. In addition, some traditional cardiac and thoracic surgical procedures are being increasingly performed minimally invasively through thoracoscopy and with the Da Vinci robot. Similarly, advances in mechanical circulatory support such as LVAD, left ventricular assist device, RVAD, right ventricular assist device, ECMO, extracorporeal membrane oxygenation, can now provide extended support for patients with refractory cardiogenic shock, advanced heart failure, and acute respiratory failure, either as a bridge to recovery, a destination therapy, or bridge to transplantation. The complexity of these advanced therapeutic options, however, has resulted in the evolution of hospitals developing multi-specialty teams, such as heart teams, shock teams, comprising of different specialties: surgeons, interventional cardiologists, advanced heart failure specialists, pulmonologists, intensivists, radiologists, critical care nurses, and perfusionists. Also, with these technological advances has come a blurring of the boundaries between the specialties, especially between cardiac surgery and interventional cardiology, as both can now be equally deployed to treat a spectrum of cardiovascular diseases. Therefore, interventional cardiologists and cardiac surgeons must work more closely together as partners and collaborators in determining what therapy is best for each individual patient. As many randomized, non-inferiority controlled trials has demonstrated that TAVR, transcatheter aortic valve replacement, has a lower procedural morbidity and mortality rate and comparable intermediate to long-term outcome compared to open heart surgery. In the United States, for example, both government and private insurance carriers mandate that transcatheter aortic valve replacement must be performed jointly by both the interventional cardiologist and cardiac surgeon as co-surgeons for reimbursement. Cardiac surgeons are now learning catheter and wire skills, which is also now being incorporated in CT surgery fellowship training. While all these advanced therapies can prolong life, they come at a huge financial cost to the healthcare system, leading sometimes to disparity and inequality to access care, even in developed countries with health insurance schemes and social safety nets for the economically disadvantaged. For low to middle income developing nations such as Nigeria with minimal health insurance coverage, these advanced therapies, even if available, are out of reach of most patients, as majority are self-pay and can't afford the treatment cost. Furthermore, the cost of acquiring these new technological treatments is often out of the reach for most public and even private hospitals. And I'll give two recent personal examples. About 3 weeks ago, a private health institution seeking to commence open heart surgery in Nigeria contacted me about helping them to source for mechanical circulatory support equipment, an ECMO, and intra-aortic balloon pump in the United States. On contacting the makers of this equipment, they directed me to their distributor in Africa, covering Nigeria, and they quoted a cost of over 300 million naira for both. The facility couldn't afford it, and they're still trying to source funds for the purchase. And I'm sure that probably only a handful of this mechanical circulatory support devices presently in Nigeria. Furthermore, about a year to a year and a half ago, I was contacted to help a one-time top Nigerian sportsman who was hospitalized and dying from advanced heart failure at one of the tertiary hospitals. The philanthropic state government had indicated their willingness to underwrite the cost of his treatment. And after we had made contact with the team at the Christian Bernard Hospital in Cape Town, who had agreed to receive him and evaluate for possible billion heart as a bridge to transplant. However, while arrangements were being finalized at the last minute, the government did not follow through, claiming the patient had suddenly gotten better, thereby losing that window of opportunity to intervene before multi-organ failure becomes irreversible. I personally think the cost implication was the main reason why they changed their minds. These two scenarios illustrate the financial barriers for healthcare institutions in adopting these technologically advanced therapies in their armamentarium to fight cardiovascular disease, and also the inability of patients to access these life-saving treatments, which is aptly captured by the conference theme, again, socio-economic burden of rising cardiovascular disease profile in sub-Saharan Africa. In addition to the challenges of equipment cost and patients' affordability, there is the other vital rate-limiting step of scarcity of trained expertise personnel to manage this high-tech equipment for treatment. This knowledge gap must be bridged to fully maximize the potential benefits. Otherwise, the equipment, even if purchased, will lie fallow to waste. A not too common scenario that I have seen at some of our Nigerian tertiary hospitals. So recognizing all these major barriers, a large population of over 200 million and the vast poverty level, recently compounded by the JAPA syndrome of healthcare professionals exiting the country en masse, seeking greener pastures abroad. We need to get out of our comfort zones and adapt to current realities by changing our present mode of care delivery for high technologically based treatments. And I know the present trend is that every public teaching tertiary hospital wants to establish a cardiovascular service line offering interventional cardiology and cardiac surgery, even if they end up doing only a handful of cases intermittently a year with the aid of foreign mission teams, just to have the bragging rights of having joined the supposed elite club of hospitals that have performed open heart surgery. However, the reality is that most of these hospitals will likely never be able to build up enough volume for their team to gain proficiency and deliver quality service and outcomes. This proliferative model of heart centers, that is, all comers, will likely stunt the growth in low to middle income countries by spreading thin and scarce resources and infrastructures. We need, therefore, to consider adopting a centralized model to harness our resources, both financial and personnel. For publicly funded teaching tertiary hospitals, it will make more sense for the government to consolidate the scarce resources to fund and adequately equip one or two of these institutions and designate them as referral centers. The selected hospital should preferably have already a sizable core of the needed expertise personnel in place. Referral centers performing regularly can accrue higher volumes and attain proficiency faster, and resulting in improved outcomes, in addition to providing more training opportunities for personnel to staff future heart centers. It is a no-brainer that we are better off with one or two fully functional heart centers delivering world-class standard of care than to have 10 or more underfunded, poorly equipped, and staffed mediocre heart programs. In the intermediate to long term, as more specialized personnel are trained and the healthcare financing and budget permits, the government can gradually establish the referral center in each of the 6 geopolitical zones for equity and perhaps political correctness. A caveat, though, for this centralized model to work is the government must support the programs with Medicaid assistance to underwrite the cost of these services, as majority of the population needing them are poor and will otherwise not be able to access needed life-saving care. Presently, majority of the open heart surgery programs in Nigeria are based on humanitarian foreign missions visited intermittently. While this model has its benefits, it's unlikely to result in sustainability unless an experienced surgeon is resident locally and able to continue with regular, even if simpler, surgeries between mission trips when more difficult cases are handled. As with the acquisition of any complex technical skills, cardiac surgery has a steep learning curve. The mission teams must be made to commit to align active participation by the local team, with them being allowed graded responsibilities so they can acquire the necessary knowledge and skills over a predetermined period of time when they can hopefully begin to function independently. The visiting teams should not just give the local team fish to eat, but rather teach them to fish so they can eventually feed themselves and operate safely independently, being the end goal. This is also in line with the 2017 Cape Town Declaration on Access to Cardiac Surgery in the Developing World, made during the 50th anniversary of the first human heart transplant by Dr. Christian Bernard in Cape Town, South Africa in 1967. And this declaration endorsed strongly the position that building local capacity is the best solution for this serious public health problem, and that many lives do have been saved by humanitarian fly-in missions. These efforts are neither sustainable nor cost-effective. And the declaration 2 aims are: 1, to establish an international working group of individuals from cardiac surgery societies and representatives from the industry, cardiology, and government to evaluate and endorse the development of cardiac care in low to middle income countries. 2, to advance the training of cardiac surgeons and other key specialized caregivers at identified and endorsed centers in low to middle income countries. With artificial intelligence and machine learning, artificial stimulators are now available for repeated practice to learn complex surgical skills in the lab as a complement to the operating room hands-on experience. The Pan-African Society of Cardiothoracic Surgeons, PASCAT, has been in the forefront of promoting cardiovascular education in Africa in partnership with other international organizations like the European Association of Cardiothoracic Surgeons and the German Heart Institute in Berlin. Since 2011, they have been organizing educational webinars, workshops, capacity building, and stimulation skills training for young and senior surgeons in low-volume centers across Africa. They have established 3 regional stimulation centers one in Accra, Ghana for West Africa, one in Nairobi, Kenya for East Africa, one in Blida, Algeria for North Africa, and a fourth collaborating center in Bloemfontein in South Africa. In 2015, all United Nations member, Nigeria inclusive, agreed to try to achieve the universal health coverage by 2030 as part of the Sustainable Development Goals. The goal of universal health coverage is to ensure that all people obtain the health services they need without suffering financial hardship when paying for them. It aims to provide healthcare and financial protection to all people in each country with three related objectives. One, equity in access. Everyone who needs health services should get them and not simply those who can pay for them. Two, quality of health services must be good enough to improve the health of those receiving the services. Three, financial risk protection. That is ensuring that the cost of healthcare does not put people at risk of financial hardship. This universal health coverage comes with the understanding of a shifting from the vertical disease silos, for example, funded earmarked for malaria, to horizontal systems-wide intervention, such as non-communicable diseases, for which cardiac surgery being a typical example. Also, in 2015, the Lancet Commission on Global Surgery proposed 6 key indicators to assess the performance of health systems and longitudinally track indicators to quantify the progress made. And the indicators are: 1, access to timely essential surgery; 2, specialist surgical workforce density; 3, surgical volume, that is, surgical procedures performed per 100,000 population per year; 4, perioperative mortality; 5, protection against improvising expenditure; 6, protection against catastrophic expenditure. Furthermore, the World Health Organization recommends that countries should achieve or target 400 open heart surgeries per million population per year. However, PASCAT lowered the figure for Africa to 40, given the existing capacity gaps. However, achieving a certain cardiac surgical volume is a complex function of capacity, which is infrastructure and workforce, case detection involving community and primary care, and financial risk protection, that is, health insurance scheme. When the Universal Health Coverage Agreement was reached by the United Nations members in 2015, the 2030 target date for attainment might have seemed so far away. However, countries without strategic planning and foresight may not achieve the goals or even come close. 2030 is only 6 years away, and there has been no visible significant evidence that Nigeria has made any progress towards this universal health coverage for its citizens. With a population of over 200 million, using the PASCAT estimate of 40 per million for open heart surgery, Nigeria should be performing approximately 8,000 per year, but we're probably presently in the range of 150 to 200. And if we include percutaneous coronary interventions, which is being used in place of coronary artery bypass in some patients, the number of the heart surgery procedures may likely increase to close to 300. In addition, as transcatheter valve therapy for structural heart disease becomes more readily available, the number will likely further increase, but still be a far cry and a small fraction of the expected 8,000 per year that our population will suggest. However, the future is not all grim and gloomy, provided there is a political willpower by the government and healthcare administrators to leapfrog and bridge the gap using models that have been used and tested and shown to work in similar climes. We can begin by low-hanging fruits by concentrating resources and effort to fund and equip one or two centers already on the right pathway to developing their HAT programs. There should, of course, be measurable objective quality metrics which can be benchmarked with best global practices, thus aligned for constant quality improvement. Continued funding could be made contingent upon meeting target metrics as an incentive to maintaining high quality. This year marks the 50th anniversary of open heart surgery in Nigeria from 1974 to 2024. Unfortunately, we have not made the expected progress or stride for many reasons, which includes our inefficient and dysfunctional health system, lack of vision and underfunding by the government, and mismanagement by healthcare administrators. However, the rot in the healthcare system is only a microsome of the maladies inherent in the larger Nigerian space. It is my hope that over the next 50 years, things will be far better if we can lay a solid foundation now and proactively strategize and plan. The healthcare space is undergoing tremendous change with the constant advances in technology. Artificial intelligence and machine learning will likely change significantly the present practice of cardiology and cardiac surgery in the next few years. And so we need to position ourselves strategically to ride the wave, as a rising tide should uplift all ships. Finally, PASCAT is organizing the first Pan-African Cardiothoracic Surgery Summit from February 22nd to 24th, 2025 in Accra, Ghana. And you're all invited to submit abstracts and to attend. I look forward to seeing some of you at that summit. Thank you for your attention.